Hi, my name is Christina Grafe, and this is my presentation on bedside rounding. Here I have various nursing staff from the emergency department. No. All right, so let's see. Bedside rounding is traditionally defined as nursing checks or rounds on a patient to pretty much ensure that their essential needs are met. Although this idea is true, in the emergency department, it must be a collaboration between the healthcare team. This includes traditional bedside hourly rounding, which is pretty much the traditional definition of it, physician to nurse report, and shift to shift report. These concepts of patient-centered care have been proven to increase patient satisfaction and improve patient outcomes. Various problems in the ER, patients are often confused about the plan of care. This decreases patient satisfaction when they don't really know what's going on. Doctors and nurses are often not on the same page when it comes to the plan of care. Doctor will walk in and tell them one thing, the nurse will go in and tell them something different. Also, decreased hourly rounding may contribute to falls and frustrated patients when needs are not met. And of course, in our ER, patient-centered care is our goal. How does the bedside rounding differ in the ED? The ED is kind of a different bird. It's a fast-paced environment. There are vast differences in patient acuity. There are short ED visits, long ED visits. Many members of the healthcare team have patient contact. You have x-ray technicians, lab going in and out, ED techs, nurses. Some possible solutions. I thought of 3 possible solutions that kind of encompass collaborative bedside rounding. The first I had mentioned was hourly rounding in the traditional sense, physician to nurse report, and bedside to shift report. So that's nurses giving shift to shift report at the bedside. What types of hourly rounding, firstly, are done in the ED? We do a lot of hourly rounding. We do vital signs, patient essential need assessments like positioning, personal needs, pain. We do specimen collection. Oftentimes the healthcare team in the ER are doing hourly rounds without realizing. So really what we have to focus on is documentation of our bedside rounding. We have the ED techs in there all the time collecting samples and helping patients to the bathroom. We just have to make sure we're documenting our work. We gotta take credit for it. Patients love updates. The emergency department is a waiting game. Updating a patient on their plan of care shows that we are doing something. It shows that the patients are not forgotten. Oftentimes, ED visits can be hours long, and updating patients and families shows a progression of care. Hourly rounding has, of course, many positive outcomes. According to a quasi-experimental study, the reported outcomes of patient rounding on multiple hospital wards reported a 12-point average increase in patient satisfaction. The study showed that when rounding was implemented, there was a 50% reduction in fall rates. Finally, there was reported 38% reduction in call bell use following the introduction of rounding. When people use the call bell less, we kind of tend to get more work done, so that's nice. The second solution is physician and nurse report. When physicians and nurses share a report at the bedside, it kind of forms a singular joint message regarding the plan of care. It's communicated to the patient and family with clarity and uniformity. It's kind of, it's a collaborative thing, and so it shows that the physician and the nursing staff is on the same page. Kind of just shows we know what we're doing. Of course, there are some barriers to this one. People will say that nurses and physicians have multiple patients, and it may be difficult to coordinate room time, which is true sometimes in the ER. It may take longer to stay in the room with the physician if they're explaining things or things like that. But ultimately, the outcomes are pretty beneficial. Patients ask fewer questions. It was shown that nurses were more aware of the plan of care, and nurses have the opportunity to place input or ask questions. So they're updated on the plan of care as well. How can we improve this communication? Effective communication is key. Some examples of effective communication is if like a nurse were to enter a room prior to the physician might say, so what have we gone over so far? Or may we discuss what I've missed? Or if the nurse, say, would enter the room after the physician was already in there, the nurse might say, respectfully, may we run through the plan, or sorry, I missed part of the discussion, may we review the plan of care. Just kind of communication back and forth between the nurse and physician, so the patient isn't asked the same questions over and over again, and it seems like the healthcare team is all on the same page. The third solution to bedside rounding and ED problems are nurse-to-nurse report. Shift report is pretty much the continuation of care, whereby existing nurses formally release and incoming nurses accept responsibility of patient care. When you think about it, it is a lot of responsibility to accept someone's work and effort on patients. We don't really think about it when we're giving a report, but we're expecting full responsibility for these patients that have already been in the ER. Proving the concept. According to a study done by University of Michigan Hospital and Healthcare, a team developed intervention to relocate shift-to-shift nursing report to the patient bedside, resulted in improvement satisfaction for nurses and increased direct care time to patients. So patient-centered care is our goal. Positive outcomes of nurse-to-nurse report at the bedside. Nurses are able to visualize the acuity of patients and the equipment. Patients are aware that a new nurse is taking over their care. Patients are more involved in the plan of care, kind of just keeping them in the loop again, even if there aren't new test results, just introducing and kind of telling the patient what's going on, just really goes the extra mile. Nurses can hold coworkers accountable for their work. For example, if an IV cartesian drip is going, you can verify the rate, because if you walk in and maybe it wasn't documented correctly, you can hold them accountable for their work. And improved prioritization. Pretty much when you go and visualize all the patients, you kind of get an initial first assessment, and it really helps the oncoming nurse, it helps them to prioritize which patient they might see first. What to include in a bedside report. Simple introduction, quick patient status, and then kind of just like a real fast overview of the plan of care. Again, updating the patient, they love those. Considerations during bedside report. Of course, some things may not be included in the bedside report. For example, personal opinions, test results that the doctor hasn't gone over with the patient yet, and confidential information that the patient may not want some family members hearing confidential information by their request. So we don't want to say that in a bedside report. Pretty much, in overall, you can be a part of the solution. You can continue to hourly round and document your work. The key there is document, because I know we are rounding very often, probably more than once an hour. We need to promote the use of effective communication between physicians and nurses during report. We need to participate in bedside nurse-to-nurse shift report. And in conclusion, effective patient care is a collaborative effort. We're not just doing it just nurses. It has to be the physicians, it has to be the nurses, ED techs, ancillary staff. Through the application of hourly rounding, physician-to-nurse report, and bedside to nurse report, it is possible to both include quality of care, their satisfaction, and of patient outcomes. And that's it.